Great. So, welcome everyone. This is Dr. Munjal Pandya. As usual, our mock test on the Sunday. I'm going to guide you for excellent few mock tests I gathered today. It's all different from the last class. So, uh, just get involved in the class and discussion. So, I would be glad to guide you well. This is Dr. Munjal Pandya, and this is medical MCQ for all those who are new student, first time joining the class. I'll give you little brief guideline what's going on really in the coaching class, right? So I will guide you everything in detail. So we are the company who provides all the things here. Medical MCQ for all is an established company in India as well as in Dubai. And recently we started one program called as EMREE, Emirates Medical Residency Entrance Exam. We launched last month in Dubai, and this we have a PROMETRIC 1000 MCQ book, online subscription, and online coaching. What today we are doing is online coaching. We also have WhatsApp subscription, Oman Viva data flow services for all specialty, from GP to consultant and super specialty. We do all data flow, exam booking, license transfer, and it done by Dr. Anjali is in our team also. So she's handling from all Dubai. We have short package, excellent package for those doctors who have, I mean, second attempt especially or third attempt with the money back guarantee package, this short package, and we provide everything in it. We have mobile application, Android and on iPhone. So those who did not download it, you can download it. And we have good dedicated mock test as well. So you can do the practice on daily basis or at least every alternate day. You do the mock test on the website. Try to check your score, how much score you are getting in each score, and then you can do the self assessment that okay, how much you are improving, what are the strength, what are the weaker areas, and where you are doing the commonly mistake. And any further discussion, you feel free to call me as well for any backup support, right? So these are the things we provide. As I told you, I'm hemat-oncologist and bone marrow transplant fellow. Have more than 20 plus years of clinical experience with more than 10 years of academic coaching experience. This is Dr. Arti, who is a consultant pediatrician. Dr. Maddy is an internal medicine cardiologist. Dr. Ankit is a gastroenterologist. Dr. Shikha and Dr. Deepa both are consultant gynecologists. Recently, Dr. Shikha has shifted to Dubai in Aster. So she is in our team. She is in this downtown Dubai Aster clinic. And this is our team and a lot more people on back end side. This is our contact details. These are the recently updated questions 1000 MCQ book, hard copy book with compilation of 1000 MCQs with answers and explanations. And we have the excellent coaching offers. As I told you, Anjali Sawant is our main backbone for data flow. So she is doing all the data flow from Dubai, and data flow, exam booking, license transfer, any queries related with the data flow or PSV, she'll gonna guide you. And that's it. And recently, as I told you, the good one feather added in our this thing is EMREE. We already launched last month, a month back almost now, going to finish 1 month. We are shortly coming up with the dental course as well. And let me tell you the quick things. For the short package and combo offer, these things are, I mean, recently we designed to accommodate each and every doctor, right? So this all 10 things will get free. Those who are in this a short package, right? Or other combo package is also there with coaching. You get hard copy free, you get ebook, you get 1 month of subscription, you get WhatsApp subscription, you get mock test, video library, weekly mock test, mobile application, recorded lectures, and lot more things. Absolutely 100% free, right? So this is the various packages. So almost there is a, I mean, more than 70% discounted rate. This all packages. So you can inquire later on. So let's first go to our main business, that is a mock test. So get ready with the discussion. I am going to guide you with excellent questions. The first questions in front of your screen. A patient had a history of pancreatic cancer on chemotherapy, then improved completely, came to the doctor concerning about the recurrence of cancers and history of many hospital visit. This patient has, what is the diagnosis? So you have here there are two questions for you in exam. What is the diagnosis and what is the treatment? So what is the most likely diagnosis? What is the most likely diagnosis, right? So you can post your this comment on the chat box. So one is a malingering, second is hypochondriasis, this is a factitious disease, and fourth is a conversion disorder. and I would like to discuss how you differentiate one from another as well. Right. So your time starts now. You can put your this in the chat box. I'll give you 10 15 seconds. 10 15 seconds. I muted all because there are a lot of background noise. So those who wants to interact, they can unmute the mic, right? And they can interact. Yes, Dr. Amina, any comment? What do you think? Yes, Amina, if you can able to speak or anyone.
Yes, sir. Sorry, I was trying to check the mute button. Yes, so in my opinion, I think the patient has it's B hypochondriasis because it's like a constant worry of something that's happening to him.
Okay, okay. So is there any another latest name of the hypochondriasis?
There was, sir, I cannot recall it, but there was. It is basically it's illness anxiety disorder, if I'm not wrong.
Excellent. You are absolutely right, doctor.
Okay,
Illness
okay.
anxiety or illness anxiety disorder. So this is the things.
So
Now tell me
it's more of
second
somebody
things.
yeah, yes,
Right.
yes,
So
sir,
this is the hypochondriasis by your experience, right? And what could be
yes,
the
sir,
treatment? So say
yes,
for example, those doctors who are coming first time to the lecture, I always give this triad. Any MCQ you are solving now onwards in any
yes, sir,
specialty, right? You need to know the three things.
yes,
One
sir,
is the diagnosis, second thing is investigation, and third thing is the treatment. So now here we have to do the
yes, sir,
two things. So diagnosis they are asking. I in exam they asking only mainly three questions. Your paper is full of three questions.
yes, sir,
What's the diagnosis? What's the investigation? What's the treatment? But for our more
yes,
clarity,
yes.
we need to know for each MCQ, we need to know all three things, right? So here we got to know that, okay, it is
G,
likely hypochondriasis. How you gonna treat this patient, Dr.
yes,
Amina?
sir.
So if you get a hypochondriasis patient,
So,
how you
sir,
gonna
yeah,
approach?
yeah.
Yeah, go
So
ahead.
for
Yeah,
any for me and any if there's any generalized anxiety disorder, we do start with behavioral therapy, which could be CBT. So we start off with that, and then we would add, if it
CBT,
isn't
that is
improved, then we would
cognitive
add
behavior
definite.
therapy. Yeah, CBT
Yes,
is
yes.
cognitive behavior
And then we
therapy.
would behavioral therapy,
And
yes. And then we will
right,
add
and
on
any
some antidepressants
pharmacological
or
therapy,
anti-anxiety.
right? So any drug name,
Sir,
if you can.
antidepressants, anti-anxiety.
And so this doesn't looks
Sir,
depression
SSRI,
basically.
Palladium. No,
This looks
no.
more of
It's
anxiety
more of
than depression,
anxiety.
isn't it? Yeah. So
G.
how you gonna
Yes,
treat this
yes, sir.
patient pharmacologically? You had given the
Mm,
cognitive behavior therapy, but patient doesn't improve much, right? Then what could be your next treatment option
G,
for
sir.
this patient?
Mm.
Any drug name
Sir, I'm not
or
sure about the
you?
drug name. Sir, SSRI koi denge,
Sertraline.
but I don't know which one.
Sertraline.
Fine.
Zoloft. Yeah.
Fine. So this is one tip from my side. In psychiatry, whenever you
Yes,
don't
sir.
know anything and any drug name you want to give SSRI. 99% time you are correct, right?
Okay, sir.
So this is one of the safest drug.
I'll
It's not a good idea, but it's in case of emergency,
take it, sir.
use the SSRI. Most of the time you are right. Now tell me anyone, how
Yes,
you
sir.
gonna
Okay.
differentiate it hypochondriasis, Dr. Amina, from malingering? What are the differentiating point? How you differentiate from factitious disorder? How you differentiate from the conversion disorder? So if you get a clarity of all these four, you are expert,
Mm-mm.
right? So our
That
job
would be
is
done.
not
Yes, sir.
just to get to the
Yes.
right answer, but our main job being a doctor is to exclude other things. Why this not? Why this not? Why this not?
G.
Right? Then you gradually develop the
G.
expertise in solving the MCQ. So do you have little idea that what
Yes.
how your hypochondriasis is this patient? Then what could be the malingering? If the malingering patient comes to you, right, how they present?
Yes, sir.
Yeah,
Sir,
any comment?
malingering के patient जी sir उसमें it's not like a disease, it's more like a behavior in my opinion. It's not associated
So
with any
can you
medical
give one
condition.
example that, sir, this is a patient who has a malingering? Any
Mm-mm.
example if you can recollect, remember anyone?
Mm.
I'm just
Sir,
trying to
No,
understand the
sir.
concept because this is a
Shortness
very
of
frequently
breath.
asked
Sir,
Shortness
question.
of breath.
can I?
Sorry.
okay, okay.
Yeah, yeah, anyone, not no need to ask anyone. This is absolutely a learning platform. So more the people will
Ji, sir.
interact, more the clarity will come. That is why we are
Shortness of breath,
conducting mock test.
Malingering,
improve breathing,
mainly,
breathing,
so sir,
Sorry,
in
heavy breathing.
malingering, mainly
one
there
by
is
one, one by
some,
one. Yeah, yeah. In malingering,
there is mainly the intention is for some external gain. So if, for example, in this case, if patient had wanted to have some leaves or want to have leaves from his office or something, so some sort of external gain, if the person is getting, then in that case, then it is considered as malingering.
okay, fine. So because of some gain or external gain, right? Probably he is on leave, right? Just to get one salary. He's like not sick, but he feeling that I'm sick, right? And he's asking for the sick leave, right? So he has
Yes,
some
yes,
gain, financial gain or whatever, right?
whatever. Yes,
Hypochondriasis is over anxiety of having something, right? Over anxiety, right? So
yes,
what is
yes.
the things? Patient has a pancreatic cancer. Understand the scenario, right? It is completely cured now, improved completely means it is cured. Patient is cured, but what the patient is concerned about, repeatedly concerned about recurrence of the disease, right? And he need lots of visit acts, right? This is one scenario, right? So patient has disease is cure. This is exactly comes in the exam. So disease is cure, but patient is still worried about the underlying disorder, and when they do the test, it is all normal. Another example, they will do repeated endoscopy or gastroscopy, repeated endoscopy, right? So patient has something wrong in the stomach. He did 10 endoscopy in 1 year, 10 endoscopy in 1 year, and all normal. Still patient concern, it is hypochondria. Third, patient does not have HIV, but patient repeatedly thinks that I have HIV, right? When you do ELISA Western blot, it is negative. So these all are the classical example. So this is a cancer or some GI complaint or HIV or some other complaints which is actually not there or cured, but still patient has a concern about that complaint, that is hypochondriasis. How you differentiate doctor from the factitious disorder, right? How the malingering and factitious things will change. What is
So I
factitious,
think
right? So
from the
this
history,
four,
uh,
yes.
yeah,
So what's the history now? You
yes, sir,
tell me
yes,
the
sir.
history, how you differentiate.
So yes,
And those who do not know, sorry to interrupt you, those who do not know all four
yes,
terms,
sir.
I request this is the homework for everyone, especially those who doesn't know. This is absolutely homework. I'll clarify in next 5 minutes all differential point for all four. But you go and read 100% questions come from this all four. Probably you get all different four questions. So not ignore any MCQs what I'm discussing because I'm doing whole week hard work to just present this 10 slides, right? Just to bring you the more clarity, right? So you must go and read. Yes, Amina, tell me now what's how you differentiate the factitious disorder.
So, sir, in this case, the history is saying that he's over worried. So, as you said, hypochondriasis is more about over anxiety. So, the history is kind of pointing towards the fact that the patient is worried about his health. So that's why he's going for follow-ups and constantly going to the hospital. So, this is one thing that's kind of pushing us towards this point that it's more of over anxiety. There's no gain behind it. He's not mentioning that he needs leave from work or he needs extra money or something like that. So that's why. I feel it's one point to put there. And then fictitious, I think for me, I need more clarity in fictitious and malingering because fictitious is also something that it's like it's there's also an external gain behind it, and you exaggerate symptoms that are not even there.
So again, one
Yeah.
last questions. Exactly what
Yes, sir.
exactly differentiate malingering from factitious? Is there any differentiating point that okay, sir, this is classical malingering, this is classical factitious, and let me come to the conversion disorder. So what's the
Mm-hmm.
conversion disorder? What's the conversion disorder? What do you understand by conversion disorder or conversion?
I think in conversion disorder, patient already have the illness and got and cured,
Yes.
but he has that fear of developing the disease again. So in this case, I think this could be the conversion disorder.
No,
If
doctor, I'm not agreed. Conversion disorder is not that. I mean, uh, not exactly what you are telling. So let me come to the conclusion of all fours. So first of all, this is
Yes, sir.
hypochondriasis, right? So let's go to the literature. It's all literature based, right? I'm not. This is all from standard books in the these things. right? So hypochondriasis illness anxiety disorder. He has a illness due to over anxiety, or illness anxiety disorder is a new term, right? Formerly known as hypochondriasis, now illness anxiety disorder. So he is thinking all the time that he has some illness, and because of that he has a lot of anxiety and become a psycho. So illness anxiety disorder, right? It's a preoccupied with having or developing a serious illness despite having only mild symptoms or no symptoms. So right, so sometimes brain tumor patient is cured of brain tumor, right? Absolutely fine, all scan MRI normal. But whenever even slight pain is in, oh, I have again redevelopment of brain tumor. So is hypochondriasis, right? Why? Because there is actually there is nothing organic, but still is thinking. So it is a hypochondriasis or illness anxiety. Diagnosis: to be diagnosed with illness anxiety disorder, the patient must have experienced anxiety about the illness for at least 6 months. Patient history may include multiple physician and multiple visits. So most important clue, tips and tricks from my side. In exam, you look for these two words, very extremely red highlighted: multiple physician visit and multiple hospital visit. That's it. So if this comes and nothing finds out, it is hypochondriasis. It is none other than hypochondriasis, right? And as rightly said Dr. Amina, that what's the treatment? So one is a CBT, that is CBT shortly known as a cognitive behavior therapy, and another is a SSRI, selective serotonin reuptake inhibitor. So this is excellent chart. I mean, one in all, right? I would like to make my job very easy for you guys. So what are the features? So first of all, hypochondriasis. So we see hypochondriasis, right? Fear of developing the disease, fear of developing the disease, but the investigations are negative, right? Or illness, anxiety disorder. What is the treatment? Cognitive behavior therapy plus SSRI, right? So this is the treatment. What you need to know, the high stem or high yield things in exam is just two things, right? How do they present? What's the treatment? That's it. So that is what I have given here. Let's come to the malingering. Malingering is, as you rightly told, fake symptoms. Symptoms are fake. There is no abdominal pain, but patient saying, "Oh, I have a lot of abdominal pain. I cannot go to hospital, or I cannot go to the work." Right? So fake symptoms, not similar to disease, to fulfill some motive. Right? So this is a fake symptom. Extremely important is a fake symptom. Apparently, there is nothing is there, but there is a the symptoms produced by the client, right? So fake symptoms, it is not there, right? Second thing, third thing is a factitious disorder, right? Now factitious is want medical attention. This factitious patient wants the medical attention, so a plethora of the symptoms similar to the disease created, right? So similar to the disease created. Again, the treatment is cognitive behavior therapy, and you can use the SSRI as well. And conversion disorder. Conversion disorder is what? The two key important: psychological stress manifest into the physical symptoms. Psychological stress. So husband, this is classical. Several times asked in DHA. Husband is beating his wife, right? So whenever husband entering to the house, wife is scared and worried that he will beat, right? So something psychological, and because of that, wife, what she developed the symptoms, mainly the neurological. Write down in your note. Mostly these convergence in, right, disorder, they develop the neurological, like blurring of the vision, right upper limb weakness, tingling and numbness in the limb, and this exactly resemble the symptoms of stroke. So you cannot differentiate, oh, whether it is stroke, right upper limb weakness, stroke, blurring of vision, stroke, numbness, stroke, right? Difficulty in speech, stroke. But it is nothing related with the organic brain or transient ischemic attack or ischemic stroke. It's all neurological symptoms. And this all neurological symptoms, right? It's a basically a psychological. Because of the psychological stress, they produce a physical symptoms. Right. So this is classical will come in exam. Same neurological will give you, but you need to know little bit things that okay, how do they present, right? So this is what the thing is. So you must go and read once again ABCD. These are the four main entity. E and F, somatization is extremely again important. Somatization, so associated with GIT, gastrointestinal tract pain, sexual dysfunction. Somatization, so they present that recurrent this GI problem or sexual dysfunction. And body dysmorphic means they are saying my lip is not good, my nasal nose is twisted, right? I my lips are not looking good. This is all body dysmorphic. So body morphology is not looking good, though it is normal. But patient comes and tell you, my nasal septum is deviated, doctor. When you do all examination, it is absolutely normal. But still, patient have repeated thought of bodily dysmorphic means something externally or some cosmetically looking not good. So preoccupied with imagined bodily defect, imagined bodily defect. There is no defect, but they imagine that there is a bodily defect. So especially only the bodily defect, imagine it is body dysmorphic disorder. And again, treatment is SSRI. So SSRI by and large works in all the psychological disorder, and there is a long list of indications for SRI. So another homework for you guys is to read the SSRI. Selective serotonin reuptake inhibitor is the full form. We'll discuss sometime in our psychiatric lecture as well. So that's it for this first question. So your job
Sorry,
not
excuse
just
me,
to
sir. Can
answer.
you,
Yes, please.
sorry to bother you, sir. Sir, can you just give little more clarity on somatization?
Somatization is associated with GIT pain and sexual dysfunction. So this type of patients are repeatedly coming with this specific complaint, recurrent pain, only one pain, pain in head, pain in head, pain in head, right? Plus they have usually present with the sexual dysfunction, right? So by and large, it's a very, but in exam, don't take it otherwise. In exam, they won't ask you all four, right? Which is resemble the same answer, right? Like hypochondriasis, nothing is there, right? But still patient is feeling. Here, nothing is there, but patient is still feeling that I have pain, I have sexual dysfunction. So they won't give you the two same answer in a one questions, right? In exam, the question is absolutely clear cut, right? It won't be overlapping. So you don't get worried. So that's it, and lot
Thank you,
more
sir.
things. Another these things for this high yield point for psychiatry. Write down very quickly major depressive disorder. You need to know, right? Indication of electroconvulsive therapy you should know. Serotonin syndrome you need to know. Serotonin syndrome. Write down. If you don't know, you just go and read it. We'll discuss. Right. I'm just trying to give you right. Obsessive compulsive disorder, OCD, obsessive compulsive disorder, right? And manic depressive disorder. This is major depressive disorder or depression. Shortly, this is a manic and depressive or bipolar disorder. So these are the commonly and general anxiety disorder, agoraphobia. So these are the few common things. It's just job of one day. If you concentrate on the high yield topics, if within one day you can completely finish it off the psychiatry part. It's not very tricky, but you need to understand the what they ask usual in the exam, right? So if you have want something more help about the topics, do contact me. I will give you the topic list, right? So that's all. So this is what the things. The next questions in front of your screen, again very interesting. A 45-year-old woman with unexpected weight loss, loss of appetite and shortness of breath present to clinic. On examination, reduced air entry and dullness to percussion in the right lung. A pleural tap is performed and aspirate sample sent for the analysis. You have told that the result reveals a protein content pleural divided by serum, or pleural says serum protein is more than 0.5 and LDH is more than 0.6 in pleural fluid. From which of the from the list below, what could be the most likely diagnosis for this patient? Is it bronchogenic carcinoma, cardio congestive cardiac failure, liver cirrhosis, nephrotic syndrome, MAC syndrome? Yeah, you post all your answer. We are 35, 40 doctors now in group. I want at least 10 answer. No? Still we have only 5 answers. I'll wait for some more answer, then I'll go. Consider this questions comes in your exam. What you gonna put this exam, right? Don't keep it blank. Never ever put these questions blank. Answer at least something. Answer what you think. Yes, Dr. Sagar. So can you explain me what is the diagnosis? What is how you investigate and how you treat or how you do the things? Yes, yes, Dr. Sagar.
Hello. Am I audible to you, sir, now?
Yeah. You are very
Good
much
morning, sir.
audible, sir. Very good
Good
morning,
morning,
sir.
sir.
Yes, go ahead.
Good morning. Sir, clinically, yes, there is dullness to percussion in the right lung. So I was trying to rule out from the options if there is anything that can cause dullness. Um, some kind of mass in the right lung or maybe pleural fluid can cause dullness. So that is one thing that I thought about. And also the patient has presented with weight loss. So that also goes in support of bronchogenic carcinoma. Regarding the ratios of protein, I am not, frankly, I'm not very much sure about that.
So have you heard the term exudate and transudate?
Yes, sir.
So what do you understand by exudate? What do you understand by transudate? So forget about
That,
this all things.
yeah,
If it is
yes,
not, it is not in the thing. Just the question is this, right? This
okay,
three lines is not there in the MCQ.
yes.
These three lines are not in the MCQ. You have the question is you are told to review your results of a patient, right, who has a pleural effusion and pleural and serum protein is blah blah blah. Last three line is the
So
question.
the
How you
sir,
approach this question?
so in that
Last three
case,
lines.
the serum protein is higher than pleural protein. So the protein has not come into a pleural fluid. So it could more likely be transudate than exudate, sir.
Okay, so now let me ask you, what do you understand by exudate and what do you understand by transudate? Here we are not mugging up the things. We are here
Yes,
to understand the real theory, topic, and
yes,
concept. So, what do you
yes.
exactly understand by exudate? Means what?
Sir, in transudate, the fluid that has come into the cavity has diffused along a membrane. So
Hmm.
in exudate, uh, it is secreted from the cells in the form. I'm not so sure.
Fine. So, how do you get to know that this is from the cells or this is coming from abdominal cavity to pleural cavity or it is coming from the nephrotic fluid or this nephrotic syndrome, the accumulation of fluid comes into the pleural cavity? How do you get to know?
Yes.
Is there any way by which you know that, okay, sir, this is exudate, this is transudate? If you don't have any history and
And
if you differentiate exudate from transudate, is there any way to differentiate between exudate and transudate? Anyone now? You got my
But I
point,
think we
Dr.
go with
Sagar.
the yeah,
The protein.
Yeah. So what things we look for basically when you want to say, okay, sir, this is transudate, this is exudate. So what exactly things one, two, three, four? What things we are looking for?
So protein cell, pus cells,
Protein cell. So pus cell. What else? So your homework is to go and read the exudate transudate. We are discussing right now. But if you do not have the clarity, go and open up the specific points, what I am explaining you today. If you do this exercise, then your Sunday is very well done. You will solve close to 100 MCQ now. In one next 1 hour, you close to you solve 100 MCQ, believe me. Because we are not just discussing one MCQ, we are discussing 10 MCQ in one MCQ. Yes, protein. One somebody told protein, somebody told pus cell. Is there anything which you are looking in a fluid when you are tapping from ascitic fluid or pleural fluid? That
LDH.
sorry, LDH. What else? So go and read my dear friends. Exudate
Sir,
versus
white cell.
transudate.
Sir,
No
white cells.
problem. White cell. So how the white cell help in the exudate and transudate? Because you told. So if protein is increase, what? If protein decrease, what? If pus cells is present or increase, what? If pus cells is absent, what? If LDH is normal, what? If LDH is increased, then what? If WBC is normal is what? And if WBC increases what and decreases what? These all are the differential diagnosis. When you are, how you gonna differentiate the pleural fluid is because of tuberculosis, pleural fluid because of autoimmune disease, pleural fluid because of any kind of malignancy. Pleural fluid is because of congestive cardiac failure. Pleural fluid is because of mesothelioma. I can tell you hundreds of things in pleural fluid. Yeah, being an oncologist, it's my daily job. So how you gonna differentiate all these things? how the pleural effusion, tuberculosis, what you can see in all four, right? Malignancy, what you see all four, CCF, what you see in four. So if you don't know, you go and open up the book, right? So that is also a homework. Otherwise, you gonna not read, just you attend the mock test. That won't solve the problem. Anyway, so this is now Dr. Sagar, where you see the dullness and where you see the hyper resonant, any condition you can think of, where is the scene the dullness, where is the hyper resonant?
So
Yeah,
dullness
go
in the
go.
fluid, pleural fluid, or hemothorax, or hydrothorax also, and if air is there, then high resonance is there.
So when there is a air, this is a lung, this is collapse. So it's a pneumothorax, right? So what you
Yes,
see in the pneumothorax?
hyper resonant,
When there is air, hyper resonant, and when there is a fluid,
then
any kind of
dullness.
any kind of fluid. It could be a pleural fluid. So pleural fluid is a clear, number one, right? Or pleural effusion. You can say simply pleural effusion. One. Then hemothorax means there is a blood. Hemo means blood, right? Hemo means blood. Pleural effusion means just the clear fluid. So one is fluid, one is a. When there is a pus in the chest cavity, pus,
Yes,
right?
then
Pyothorax. Pyothorax. Have you heard of this pyothorax or empyema? You
yes,
can
yes,
say empyema, right? So this is all fluid, right? So this condition where you get, right, there is a
dullness.
dull, right? So this is what the thing is. So it could be in the pleural effusion, can be in the tuberculosis, it could be a mesothelioma, it could be a malignancy. So anywhere, what my main job is to give you the concept. Whenever any fluid, whether it is a fluid or blood or pus, any kind of liquid is filled up in the things, you get the dull note. Then you need to differentiate what dull, blah blah, right? But this concept you should have in your mind, right? Number one. Number two, this is, even though if you don't see this, Dr. Sagar, if you don't see this, 45 years of old woman, unexpected weight loss, unexpected or unintentional weight loss, loss of appetite and shortness of breath. Why she has a shortness of breath? Because there is a pleural effusion, the fluid in the pleural cavity, right? And dullness. See the dullness. Dullness means fluid, right? So there is a fluid. So it is not seen in the much in the congestive heart failure. You do not see this, all called the constitutional symptoms, for your knowledge. Constitutional symptoms, in book you go and read constitutional symptoms. So unexpected weight loss, reduced appetite, fever, these all are the constitutional symptoms. Sometimes bone pain as well, right? So this is not seen in any things, number one. By that way, it is a bronchogenic carcinoma, number one. Number two, just for whenever you see the pleural fluid, most important investigation is to do the tapping. Any case of pleural effusion comes to your practice, right? No need to do, whether it is a leukemia, lymphoma, tuberculosis, malignancy, mesothelioma, nephrotic, whatever the cause of pleural fluid, first do the tapping. Send for two things: cell count, cytology. This is how we practically do in my practice in lung cancer. Every day I'm doing this job. So cell count will give you idea about what is the WBC count, increase, decrease. It is infective, non-infective, and cytology will give you idea about the malignancy. So this will give you idea about somewhere infection, and this will give you idea about the malignancy. And third thing is that we will in pleural fluid, what we will do. So I'll check the pleural fluid protein and serum protein. So pleural fluid means I am doing the tapping from the pleural, and I am asking what is the albumin in the pleural fluid, what is serum albumin. I do the ratio. If it is more than 0.5, right, it is exudate. And LDH, I also check the LDH. So I check LDH, right, pleural LDH and serum LDH. If it is more than 0.6, it is exudate. That's it. So this is more simplest example, right? And exudate is happen either in infection, malignancy, and pulmonary embolism. So these are the three indication common where you can see the exudate. So that's the thing is. So let's go to the literature now. So this is excellent chart. I got it for you. It's called slice criteria, right? So what is the transudate and what is the exudate? So if you have protein plural plus serum, if it is more than 0.5 and plural and serum LDH is more than 0.6, it is exudate, simple. So whatever, if you have history, no history, nothing, this is the simple. And what are the causes of exudate? And these are the causes of exudate. These are the common causes of exudate: infection, malignancy, pulmonary embolism. That's it. That's it. So this is as simple as that. So you don't need to mug up. You don't need to mug up. You don't need to mug up, right? So this is what the thing is. Dr. Sagar, you got the idea what I'm trying to explain. Sagar,
Yes, sir. Thank you, sir.
right? So you need to basically understand this simple chart, right? So you
Sir,
can understand. But
serum is always collected from the blood sample, I think.
yes, blood sample. That's correct.
Okay.
From the
Both
blood
the
sample.
sample we have to send.
Yes. So I mean, you collect the 2 ml of blood and send
Yes,
the
sir.
and you collect the pleural fluid as well, and you ask for
Yes.
both the things, right? You don't need to
Okay, sir.
double puncture. Na? From one sample, one you
Yes.
send for the protein, one you send for the LDH. That's it.
Okay, sir.
And check the ratio, what's going on, right? If it is
Yes, sir.
either, there is a two possibility, either 0.5 up or 0. Less than 0.5. That's it. There is no third options, right? So you need to see it. That's it. So this is what the thing is. So this is simple, tricky, but you need to know, right? So many a times you are, I mean, reading, I mean, this all exudate, transudate, but we get confused. So I just try my level best to get you a bit more clarity about exudate, transudate. So lots of questions comes. So this is one example, but they may ask you something different. They may ask you ascites. They may ask you nephrotic. But the logic is what you need to just concentrate on the history and what are the LDH and protein. That's it. So if you know the basic, you can answer any question. So next questions in front of your screen. A 3-year-old boy is brought to the ER emergency department by paramedic. He was found unconscious after motor vehicle accident. Upon presentation, the patient is need to have multiple mandibular and maxillary fracture as well as an open right-sided tibia fibula fracture. The patient remains unconscious. Oxygenation was 78%, 2-liter oxygen via face mask with pulse of 146 per minute and blood pressure is 60/20. Which of the following is the first next step in the or first step in the management of the patient? Administer the IV fluid because blood pressure is 60/20. Continue with the face mask ventilation, right? And proceed with the rest of the primary trauma survey. Why? Because as SpO2 is 78%. Proceed with the cricothyroidotomy. Proceed with the nasopharyngeal intubation and proceed with the oropharyngeal intubation. So take your own time, think over it for 10-15 seconds, what it could be and why it. My main job is to explain you why, not just the A. So if you give me answer A, I will ask you why not B, why not C, why not D, and why not E, vice versa.
Sir, because A should be because administer fluid to maintain the hemodynamic, the vitals should be stable first. So ABC we have to
Okay.
go for
You are Dr. Dania, right? So now
Alia.
tell me, Dr.
Alia.
Dania,
Sorry.
how you manage this patient? So what's your protocol? If the same patient comes in your emergency room, how you gonna go for this patient?
Sir, A and
Everything
B.
is important. Yeah.
Sir, B.
A and B. Both. We need
So
it.
what is
We, we have to maintain the airway.
I
And
want to have one answer. Right now, one answer. A, B, C, D, or E. So you tell me one answer first of all. So we'll discuss.
B is a more specific,
Which
but we
one?
cannot ignore the administer. The B, the continue with the ventilation and proceed with the rest of primary trauma
Face.
survey.
Okay, so face mask ventilation. So do you think in a very bad facial injury and
No, no,
mandibular
no.
injury it would be effective? Because they have clear cut mention
Oh,
multiple mandibular and maxillary fracture. There are a lot of fractures, but mandibular and maxillary fracture, when you have multiple facial, maxillary, mandibular, do you think this facial mask would
so
be that effective in
no,
this
no,
patient?
no.
Okay,
No,
so
no,
now
no.
what's
There
the next
should be
answer?
nasopharyngeal intubation.
Okay, nasopharyngeal. So what are the indication and what are the contraindication of doing the nasopharyngeal intubation? Can you give me only one
No,
contraindication where
sir,
nasopharyngeal?
I'm really sorry. It's a ET tube
Facial bone fracture,
ET
sir.
tube, oropharyngeal.
Okay, so
Nasal fracture.
okay, so
Nasal
again,
fracture.
okay, nasal fracture, fair enough, right? So maxillary is like very close to nasal fracture. What is the oropharyngeal intubation?
CSF leakage.
And what is the contraindication of nasopharyngeal? I mean, sorry, oropharyngeal, Dr. Dania? What is the
Or
contraindication of doing the
oral growth.
oropharyngeal intubation? Where you cannot do the oropharyngeal?
Oral growth.
Oral growth. Okay, fine. Where you cannot do what else? Only oral growth. Without oral growth, you can all the condition where you can do the oral growth. So
Mandible
what are the
fracture.
third?
Similar
In this
Fracture
case,
similar
mandibular fracture.
contraindication in
Mandibular fracture.
facial or oral, yeah, facial or oral trauma, we can't do it.
So again, the facial and oral trauma we can't do it, right? This is nasopharyngeal, again facial and nasal and oral we can't do it, right? Administer the fluid will not kill the patient. Always remember in emergency, don't miss ABC, airway, breathing, and circulation. So now we have two close options, right? B or C. Three A is gone, D is gone, this gone. This is how you have to interpret in your preparation at home. You can't just give the answer, right? Continue first. So when face and mask is not effective, especially facial and mandibular injury, right? So what the answer perfect is the cricothyroidotomy. That could be the best. I'll explain you a bit more in detail in next 1 minute, right? So everyone those doesn't know, I request and urge you nasopharyngeal airways, oropharyngeal airways, cricothyroidotomy, and tracheostomy. Basic things. Just only you need to know two things. What is the indication? What is the contraindication? That's it. So this is again a third homework. I know what homework I had given you. So this is third homework, right? So you go and read it, right? You go and read it. There are a lot of things. Airway we can take one whole day, but just to make it quick. So here the answer is a cricothyrotomy. What is cricothyrotomy then? This is the anatomy. So you need to understand the anatomy. So this is a cricoid cartilage. This is hyoid bone. This is upmost on upper, right? This is hyoid bone. Below that, it is a thyroid cartilage. So this is a thyroid cartilage. And below thyroid cartilage, there is a cricoid cartilage. And between thyroid and cricoid cartilage, there is a ligament that is called thyrocricoligament or cricothyroid ligament. So this is the ligament joining this, right? So thyroid and cricoid, this is thyrocrico or cricothyroid ligament. And this is a trachea, basically. So what you need to do in emergency, right? The best way is to do the cricothyrotomy. You just make a directly puncture with the scalpel, directly puncture in the cricothyroid ligament. Airway is absolutely open within 1 second. Within 1 second, and it is the best. It is the best in any emergency. If you don't know, right, and airways compromise, hypoxia, if you don't know anything, do this cricothyrotomy. And especially when there is a facial, mandibular, or maxillary injury, you must go for this because when you have facial, oral, maxillary, probably you have cervical injury. Endotracheal intubation is not good idea at this point of time, right? Until and unless you do the triage, you make sure that there is no cervical injury or otherwise there is no other contraindication to do tracheostomy. Your job is to just two things: airway, two word important airway. One is a secure airway. So by doing this, you secured airway, and second important one is a maintain airway. So you need to secure and you need to maintain. That's it. That's it. So this is what the emergency do, and you must know the next step is what is the main clinical important point cricothyrotomy versus tracheostomy. So let me tell you very importantly that cricothyrotomy is used in emergency. So within second you can do. What are the advantage of cricothyrotomy, right? So in emergency you do. This is usually a temporary airway, not permanent airway, while this is a long term or permanent airway. So patient, if you want to put on the ventilator, patient has acute respiratory distress syndrome, you put it on endotracheal intubation. You can put it for 1 week, 2 week, 3 week. It's a long term. This is temporary, but it is a life saving. It's in emergency, right? Third thing here, the fiber optic view is not required. You don't need any fiber optic things, nasal, cannula, or some fiber optic visual things. You just blindly puncture in front of just above the sternum is a cricothyroid ligament. You just puncture it. That's it. Local anesthesia is not required. So this all advantage. Emergency you can do, fastest you can do, no fiber optic required, no anesthesia required, right? Less bleeding and less complication can be done in any patient, especially the obese patient, and it is simple and it is speedy. These all are the advantage. All are the advantage. Opposite way, right? Tracheostomy slightly more time consuming. Obviously, why? Because you need a blade. You need to give the position. You need the expertise. Everybody cannot do tracheostomy, right? You need to put perfectly within the trachea. Instead of trachea, if you put it in the right bronchus, right, the tube, then left lung is collapsed because inflation is only in the right lung, right lung, right lung. Air is going into the right lung. Left lung is within few minutes or hours. Left lung is collapsed. So some technical expertise is required. Here, no technical expertise is required. Anybody just puncture it, done. It's life saving, right? Long term maintenance, you do the tracheostomy, especially in all ICU patient. If you see and go and visit your ICU, nobody is on cricothyrotomy. They all are on tracheostomy. It's in the emergency room. It is usually in the ICU. Once the patient is stable, secure the airway, then you permanently, from earlier when patient comes to emergency, you did crico. But if the patient required long term, especially the mass in the hypopharynx, right? Mass in the hypopharynx, right? You need a long term airway maintenance, then you switch to the tracheostomy, right? Fiber optic is required, recommended, right? Sometimes anesthesia is required, need more expertise, usually for the ICU patient, ideal for upper airway mass. So these are the pros and cons. These are the advantage, disadvantage of this. So you need to understand. So in short, nutshell is when there is an emergency, you do the cricothyrotomy. But when you feel that it is a long-term access is required, you can switch from crico to tracheostomy. And all patients in your hospital and my hospital in ICU is on tracheostomy, right? So these are the things. So cricothyrotomy is very, very important life-saving emergency procedure. Hopefully, I am clear from my side. Is there any question? Is there any question?
No, sir. No, sir. It was very clear.
Wonderful, excellent, brilliant. So I'll switch to the next question. Which of the following organism would typically be found in a patient with atypical community acquired pneumonia? Atypical community acquired pneumonia. Options are Staphylococcus aureus, Pseudomonas species, Streptococcus pneumoniae, Legionella pneumophilia, and Haemophilus influenzae. So I want those who are debating, I need 3-4 things, right? What is community acquired pneumonia and what is hospital acquired pneumonia? One question, right? What is a curve 65 score in community acquired pneumonia? What is the commonest organism in community acquired pneumonia and organism in community, and same way in the hospital acquired pneumonia? What is typical pneumonia versus what is atypical pneumonia, right? And what pneumonia associated with other comorbid condition? Take a photo of this, whatever I am writing, this 100% comes. Top 10 leading cause of death across the globe is pneumonia. One of them is pneumonia. So you go and review the literature of WHO. I reviewed many times. So you go and read it. So pneumonia is a very, very fantastic questions in the exam. Hundreds of questions related with the pneumonia. So this is one of them. What they are asking, which of the following organism would typically be found in patient with atypical community acquired pneumonia? But we need to know all five. What is community acquired versus hospital? Curve 65, commonest organism, typical, atypical, right? And pneumonia associated with some comorbid condition. Because these are all exam questions. Yes, Dr. Hina, would you like to comment? Dr. Hina?
Sir, it is a D, Legionella pneumonia, pneumophilia.
Legionella pneumonia. Okay, so now first
It is
off, tell
atypical.
me. Okay, fine. Your answer is correct. Answer is perfect. So for this point, answer is correct. Okay, so answer is Legionella. That's all done. Right? Now tell me how you differentiate between typical and atypical. Is there any criteria? Is there any guideline? Is there any things which differentiate that, sir? This is typical, this is atypical. How we gonna make this word typical versus atypical? What's the thought
Sir,
process in your mind? Yes.
typically only involve chest symptoms like fever, SOB, like this. And
So
atypical pneumonia
one
involve
second, one second, one second, one second. So fever is there in what? Typical or atypical or both?
both
Okay, so fever
high
is here,
grade
fever
fever,
is here. Shortness of breath. I'll write down little shortness of breath. So where is the high grade fever is where? Typical or atypical?
typical.
Typical high grade fever. So here the what is the pattern of fever in atypical?
Low grade fever,
Low grade fever.
around
Okay,
100, 101.
fair enough. What is the shortness of breath and here shortness of breath? What's the difference?
Shortness of breath, minus plus occasionally in atypical pneumonia because it involves systemic symptoms also like
So here
diarrhea,
the
mileage.
here the shortness of breath is what we go by symptoms. So shortness of breath, how you define here and how you define here.
As shortness of breath, possibly, maybe atypical.
Maybe in
In atypical, SOB maybe
maybe
or
here
may not be.
maybe or may not be. Fine. On here, same maybe and may not be.
It present in
Okay, fine.
pneumonia,
So
typical
maybe
pneumonia.
may not be by your opinion. Maybe what other things can differentiate from typical atypical? These two things or something else as well. If you
Cough,
do the chest
purulent,
X-ray, if you
purulent
do the
sputum.
chest X-ray, what you see in the typical and what you see in atypical. If
In
there
the
is a
typical,
sputum is
In
there, if sputum is there, what is there in the typical? What is there in the atypical?
sputum, there purulent sputum like greenish, copious sputum, and typical pneumonia.
Okay. So what are the organism in alcoholic patient with pneumonia, diabetic patient with pneumonia, homeless patient with pneumonia, septicemia patient with pneumonia? Lot of difficult question. I think I asked you.
So it is all
We'll discuss.
related to, I think, atypical pneumonia.
Fair enough. So now this is understanding. I want to make one concept in your mind and brain that how you differentiate, right? Especially in a community acquired pneumonia, right? So community CAP is a community acquired pneumonia, another is a hospital acquired pneumonia, right? So once you are in community, you develop community. The name itself, it acquired from the community and it acquires from the hospital. So say for example, patient today is the 13th of October, admitted to the hospital. At that time, he has no symptoms, no cough, no fever, no sputum, no chest pain, no dyspnea, nothing. He was fine. He came with the appendix operation. But after 5 days, on 18th of the 10th, he again presented with a fever, cough, dyspnea, blah blah. So after admitting to the hospital, he developed pneumonia. That is called a hospital acquired. No need to mug up. Just remember the name itself suggests hospital acquired pneumonia. Once patient get into the hospital, he developed pneumonia and it usually developed after 48 to 72 hours of hospitalization. So he came 10 o'clock and 11 o'clock, he don't, won't develop pneumonia, right? He develops some resistance strain within 48 to 72 hours after getting contact with the hospital environment. That is hospital acquired pneumonia for your knowledge. So one question is answered. What is community? What is hospital? Typical is sudden onset. This is extremely important. All of the sudden it's typical. This is gradual. This is gradual. This is gradual, right? Here
Sir,
the
so the
cough
typical pneumonia is
productive.
always sudden onset.
Yes. So typically sudden
Okay,
onset,
fine.
atypical is gradual onset. Gradually means slowly, right? Patient over a period of 5 7 days he develop gradually, slowly, right? Here all of the sudden patient present in the emergency with breathlessness, sudden onset. Productive cough, here non-productive cough. Again, very important differentiating point. Productive means he has a sputum. What kind of sputum? Usually it is a purulent, means like pus kind of whitish or yellowish or bloody sputum. Right here, the usually non-productive, so they did not develop any sputum, so it's non-productive. Typical is usually high fever. Here the low fever, as Dr. Hina told rightly. Right, evident local sign, minimal local sign, evident local sign. Myalgia headache are uncommon. Here the myalgia and headaches are common. Focal, alveolar and lobar infiltrates. Here the diffuse. So COVID-19 is atypical. COVID-19 is atypical. This is focal. Right upper lobe, there is a consolidation and diffuse means both the lungs bilateral be diffuse interstitial infiltrates in the chest. on the X-ray, right? And here this is usually bacterial, typical. So there is a leukocytosis. Here leukocytosis is uncommon. Example, COVID-19. So this is just for your, it is not applicable to 100%, but this is a general demarcation. So this is how you get to know clinically. So if the patient comes to my OPD, I want to know whether this is typical. Culture, everything will come afterward, not immediately. And culture report across the globe will not come in before 48 hours. Any laboratory in the world 48 hours before, because when you do the culture, they grow in the culture media, right, in various medias specific, and then they grow, and that comes after 48. So what will you do for 48 hours? By this way, you can know that this looks like a typical. Why? Because patient has sudden onset, patient has a sputum, patient has a high fever, patient has a leukocytosis. So this is likely a typical pneumonia. Patient doesn't have, it's slow progress, no sputum, counts are normal, diffuse infiltrate in the chest, likely atypical. That's it. So this is what you can, I mean, little make your clinical sense more powerful, right? And then organism. So this is first the clinical. This is absolutely clinical, an X-ray, right? Nothing hi-fi. Now organism, come to the organism, right? So come to the organism. So these are the organism which is atypical. Atypical. What are the things? Legionella pneumophilia, chlamydophilia, pneumocystis carini pneumonia, especially in HIV patient. So these are the atypical, and the also the COVID-19 recently. This is the old this paragraph. I mean this chart, right? So this is what you need to understand, right? And depends on this what antibiotic acts on that. That is the homework. So I'll share this PowerPoint with you. So you keep in mind. And another is a curve 65. Curve 65, right? Any community acquired pneumonia, you need to know curve 65. Can anyone know what is curve 65? What does it mean by curve 65? So C means confusion,
Sir,
U means
yeah, I just
uremia,
know what it stands for.
Urea,
Yeah,
R means
respiratory
respiratory rate,
rate.
BP, and 65 is
BP and
age.
65 age.
So if the patient has any criteria, it carries 1 point, right? If the patient has a confusion, score is 1. If the patient has uremia means more than 7, it is 1. If the respiratory rate is more than 30 per minute, score is 1. If BP is systolic less than 90, score is 1. If the patient is more than 65, say for example 67 age, right, then it is a 1. So total maximum there is a score is 5. People are background noise literally irritating me. I don't know. I cannot concentrate well. Why they can't make a
Sir, maybe
mute
you
their
can
mic? I
mute
don't.
all of them. Sir, maybe
Yeah,
you
but
can
I
mute
mean,
all of them.
yeah, but they should understand. I mean, they knows no, they are attending 100 times. It's not first time. Anyway, so yeah, so each point contains 1 point, right? So there are maximum, minimum 0, maximum 5. If nothing is present, 0, 0, 0, 0, 0, minimum 0, 1, 1, 1, 1, 1, maximum 5. Why we need to know this? Because 0 and 1, low risk, right? 2, 0, 1, 2, 3, and 4, 5 in general, right? So this is called mild pneumonia, moderate pneumonia, severe pneumonia. Here you can do it in outpatient department, OPD. You can treat all pneumonia, does not require admission, depends on the curve 65 score. So you need to check curve 65. Even your senior, your junior, or your resident, or your boss does not tell you to count the curve 65. In every community acquired pneumonia, you measure the curve 65 by, because you need to take the decision whether I should admit this patient or not. How you gonna take decision on that? So curve 65, see this all five. If no if confusion is there, this all five there means it is a very sick patient. All five, maximum five. So higher the number bad, right? So mild, moderate, and severe. Mild, you may be treat OPD. Here OPD versus IPD depends on the patient, and they must be admitted in IPD and ICU. They should be supported well. Why? The mortality here is, say for example, 5% or less. Here the mortality is 10 to 20%, and here mortality is more than 30% mortality. Means death. Right? So you cannot leave them alone. Now, okay, 4 to 5 score comes, you go home. I'll give you azithromycin, I'll give you doxycycline, I'll give you macrolide, I'll give you some respiratory fluoroquinolones. You go home, rest. Don't do that. 4 or 5 must admit the patient. They will high chance of death, because patient is absolutely unstable. Why? Because consciousness is not good. renal function is not good, his respiratory rate is bad, his blood pressure is very low, and he is an elderly fellow. That is why the score is 4 to 5. So you must admit and treat the patient, right? So that's it. So this is what the logic is. So we must need to know the things, right? And this is what various kind of the literature I have given. Last but not the least, this is the tech. You can take the picture because I did a lot of exercise to compile this. This is again a last questions. I mean, for this pneumonia, if the patient has a recent history of recent viral infection, causative organism could be staphylococcus. If patient is alcoholic, develop pneumonia, likely, this is likely or likely, but it is very important for you to understand and know to adjust the antibiotic. Every pneumonia doesn't have the same antibiotic. Typical, you may use different antibiotic. Atypical, you may be used different antibiotic. Community acquired, you may be different antibiotic. Hospital acquired, Pseudomonas klebsiella may use the different antibiotic. So alcoholic patient Klebsiella, recent infection Staphylococcus, gastrointestinal symptoms along with pneumonia could be Legionella, that is atypical, as we are discussing. Young healthy patient and they have pneumonia could be likely mycoplasma. Patient present at the birth, oh sorry, it's not different, sorry. Arizona construction work, coccidiomycosis. So this exactly comes in the picture. Patient is working in Arizona. Patient is a constructive worker. What could be the cause of pneumonia? Coccidiomycosis. HIV patient develop pneumonia. PCP, pneumocystis carini pneumonia. Drug of choice is Bactrim DS. Sulfamethoxazole and trimethoprim. We'll discuss sometime. Fair enough. So you need to know this all seven various varieties. These are all seven MCQs in exam. Why? Because there is no repetition, right? If you have infection, recent viral staphylococcus, if you have HIV, PCP, if your gastrointestinal symptoms is Legionella, young healthy mycoplasma. That's it. So you need to know, you need to understand, right? So these are the tips I written here as the tips. So this is tips for you, right? So you can take a picture. I will share the things with you, right? So that's all for pneumonia. So you must know the 4 5 things. What is community and hospital? If you don't know, once again revise from master the board. Excellently well given in the MTB 2 3, right? Second is community versus acquired, curve 65, atypical versus typical pneumonia, and specific associated young adult viral infection, alcoholic, diabetic, right? And HIV positive. What is the cause? That's it. Next question. Is that clear to everyone? Yes or no? Dr. Hina, I think I'll try my level best to make it more simplified.
Ji sir, I'm clear. Thank you.
You got it, right? So now any
Ji sir.
patient comes to your OPD tomorrow, right? Monday would be heavy OPD for everyone. So just look for the typical versus atypical. Keep all things in mind. It's not just keep limited up to the books. You should apply all the knowledge what we have in the clinical practice. That's it. So next questions in front of your screen. Which of the following is the most appropriate screening for aneurysm? So I have 2 3 more questions, right? So one question is this, and second question is what is the treatment of triple A? Means aortic abdominal aneurysm by size. If size is 2 centimeter, what is the treatment? 4 centimeter, what is treatment? 6 centimeter, what is the treatment? So first we understood the question. Which of the following is most appropriate screening test for aortic aneurysm or abdominal aortic aneurysm? Everyone more than 50 with CT and angio you should do. Men who have ever smoked age more than 65 with ultrasound, they are asking about the screening test. So what screening test is most appropriate for this triple A? Everyone with 50 years of age you routinely do, everyone with more than 65 with ultrasound you do, or man age more than 65 with ultrasound you do. Take your time, take your time, take your time. Dr. Pooja, are you okay to discuss?
Yes, sir.
Wonderful. So what's your answer? First off, what's your answer?
B, sir.
B.
Yes.
So why not D? Because D is also everyone aged 65 and men who ever smoke above 65. So this is 65 above with ultrasound. This is also 65 with ultrasound. So why you selected B? Why not D?
Because smoking increases the risk.
Smoking is increases the risk. Excellent. Smoking increases the risk of aneurysm, right?
Yes, sir.
Fine. So that's the answer. So answer here is a this. Okay,
B.
fine. So this is one thing we should know. What is the screening test? Let me give you three options: ultrasound, CT scan, MRI, or PET scan. This is another question in exam. What will you select?
Ultrasound.
Ultrasound. Excellent. So this is ultrasound. It is easiest, it is fastest, it is cheapest, it is cost effective, it's available everywhere. That is why ultrasound, not just the ultrasound. Why ultrasound? I explained you four reasons, not one reason. Second thing, third reason. Puja, if it is 2
Yes, sir.
centimeter and patient is asymptomatic, how you manage? Now comes to the treatment, aneurysm. So in this scenario, you found right. So you did aneurysm, and here the question further. Aneurysm size is 2 centimeter. Patient is asymptomatic. What is the management? Second question.
Uh,
So now tell me.
so ultrasound every 2 years, sir.
Ultrasound every 2 year.
Yes.
Okay, I'm writing. I'll tell you right or wrong. Now
Okay.
this patient has a second question. 4 centimeter and asymptomatic. What is the treatment?
That is ultrasound every 6 to 12 months.
Every 6 to 12 month ultrasound. If this
Yes.
patient has a 6 centimeter of aneurysm, patient is
Surgery.
asymptomatic. What is the treatment?
Surgery.
Surgery. Why you want to do the surgery for this patient? He is asymptomatic.
Because the size is more than 5.5 centimeters.
Okay, 5
He
point. What
recommends.
happens if it is more than 5.5 centimeter? What all of the
Rupture.
sudden went wrong? Sorry?
Rupture can happen.
Excellent. Rupture can happen. So you are worried about rupture or shock or intra-abdominal massive bleeding or intra-abdominal hemorrhage, right? That is what you are worried about,
Yes.
isn't it? Yes
Yes,
or
sir.
no?
Yes.
So
Yes,
that's the
sir.
story. You are absolutely right. Going well. So this is how we have to understand the every question. So correct answer is men who ever smoked and age is more than 65, not 50. Remember, not 50. So two criteria, 65, right? And smoker. So these are the two criteria, smoking and 65, right? And what is the modality of the screening is ultrasound, not CT scan, not MRI, not PET scan. Is that clear? Now size and symptoms. So here aortic size diameter of aneurysm. So what is this? Say for example, this is normal abdominal aorta. And what is aneurysm? This this is aneurysm is like a balloon, right? So this is a aneurysm. It's like a balloon, right, in the aorta. So it's a high chance of rupture. So 3 to 4.4 centimeter image at yearly interval. So Puja is never a 2 yearly, just for your knowledge. Puja,
Okay, sir.
right? So it's not a 2 yearly, it's a yearly. So when this up to 3 to 4.4, this is as per the book. Huh? Whatever I'm producing here is not my literature, book literature, standard book guideline, right? So 3 to 4.4 centimeter yearly interval, right? Aortic, and if it is little larger, 4.5 to 5.4, right? Little more closer, right? 3 monthly, Puja, three
Yes, sir.
monthly, not 6 monthly. And third,
Okay.
anything more than 5.5, anything more than 5.5, 6, 7, 8, 9, anything more than or equal to 5.5, or there is a one word, or rapid expansion more than 1 centimeter per year. How do you get to know? Because every yearly you are right. So 4.4 after 1 year it is a 5.4. So 1 centimeter per year increase, 1 centimeter per year, 1 centimeter per year means fast expansion. You must go with the surgery, even though asymptomatic patient. Even the patient is asymptomatic, and obviously symptomatic patient you can't wait, na? Any all symptomatic patient irrespective of size. So you have 3 centimeter of aneurysm, but patient has abdominal pain and develop hypotension means there is a rupture of abdominal aorta. So don't go through your, oh sir told 4, 5.5, 4 up to 5.54, you just monitor 3 monthly. Doesn't require. All asymptomatic patient, this rule will follow for asymptomatic patient. For symptomatic patient, no rule. Symptomatic patient plus AAA, surgery. That's it. One line. One line. Symptomatic AAA surgery. Asymptomatic, follow this. Asymptomatic up to this size, yearly USG. For this size, 3 monthly USG. More than 3.5 without any symptoms, open up. Repair. That's it.
Okay,
Pooja,
sir.
is that clear?
Yes, sir. Yes, sir.
Any confusion?
No, sir.
Wonderful. So you answered well. I'm happy. Anyway, great. So just keep watch on it. So next questions in front of your screen. And otherwise, I hope this all clear, right? This, I mean, not very tricky questions, but important. And it is very commonly seen in a clinical practice because whenever you are going for some abdominal pain for other reason, probably you are suspecting some renal stone, but on the USG, elderly people found, oh, there is aneurysm in abdomen. What to do, right? So you go with this asymptomatic, follow this guideline. That's it. Next question. An otherwise healthy 22 years old female presented with headache over 2 weeks with was like and more intense on back of head and often precipitated by emotional stress. Examination, general and neurological is okay within normal limit or unremarkable. What is the most next appropriate step in the patient's care? Are you going to start antidepressant, calcium channel blocker, ergometrin, right, containing preparation, or NSAID, or sumatriptan, right? And here the my red line is what is the diagnosis. So again, my triad will come in picture. So this triad will not go away in any MCQ. So first of all, you need to know the diagnosis. What they are here asking is the treatment. So tell me how you gonna do the treatment without knowing the diagnosis. So first think of diagnosis and then A, B, C, D, E. Think over it. Think, give some mind, do some brainstorming. What is the diagnosis? It could be a tension headache. It could be
So it
a
would be
anxiety
tension or
headache.
cluster
It could be
hemorrhage,
emotional headache. It could be a cluster headache. It could be a migraine.
cluster head.
So these are the differential diagnosis, though they will not give you in the exam, but I am giving you. Yes, Dr. Amit Gangurde, what could be the diagnosis first of all? What this pain, what this pain is describing for what? Description of this pain is of which pain? Dr. Bahar Toprak, any comment? You commented sumatriptan. So what is sumatriptan?
Yeah, its diagnosis is migraine, and is sumatriptan is first treatment for migraine.
Yes, so your diagnosis is migraine or migraine, right?
Yeah.
So how you differentiate this from tension headache? And how you differentiate migraine from cluster headache? And this is migraine headache. Just trying to understand how you differentiate from the pseudo tumor cerebri, and last but not the least, how you differentiate from the temporal arteritis. All five things will present with the headache. This is how you have to prepare in your exam, and when you are reading at the home, you don't need to just know the answer. You need to know all differential diagnosis. Then you become expert, right? So how you differentiate Bahar from this, from this, from this, and from this and this? Tell me. So first of all, differentiate between you describe me migraine headache and you describe me the tension headache. That's it. How these two doctors, I mean patient present. Forget about all three.
Migraine headache is, sir, with photophobia.
Photophobia. What is photophobia?
Photophobia are relationship to men's associated with food is
So
prescribed by emotions.
So if I tell you by the history how you gonna differentiate between migraine, so migraine is unilateral or bilateral, tension is unilateral or bilateral, it is frontal headache or it is occipital headache, it is associated with aura or not, it is associated with nausea, vomiting, and stress or not. So this is all you need to know the specific things for every headache. then you become, because there is no investigation, no CT, no MRI, no brain, no angiography will diagnose the headache, right? It's a clinical diagnosis. All is clinical. Tell me how you diagnose all five. Tell me, is there any test for this migraine headache 100% diagnosis? Do you know any investigation, radiological or biological or chemical? No. Tension headache? No. Cluster headache? No. It's all history, right? How they present, you diagnose the things, right? So now let me go to the chart rather than these things. So this is the chart. This is the chart from book as it is, copy paste. Headache management. So before management we go. So first we go the tension headache. Type is tension headache. How they are? They are the bilateral band-like pressure. Bilateral band-like pressure. Last for 4 to 6 hours. Normal physical examination. Obviously, most of the time examination is normal in tension headache. So name itself suggests some tension of headache. I mean family, friends, financial relation, blah blah. It's a tension headache, right? And it is a this diagnosis of this is a tension headache. Our scenario is tension, right? Band like or vast like. I'll show you the picture. What happens in the migraine headache? Aura is extremely important. Aura. Photophobia. Somebody told, doctors told aura, right? So aura and photophobia. What is photophobia? Word photophobia. Anybody knows photophobia?
Fear
The
of
light,
light.
yeah, the light
Patient
triggers, it's like
destructive
the intolerance to
lights.
light.
Insensitivity
Yeah.
to
Yes, that's correct. That's correct. Right. So photo means photo light and phobia means fear. Right. So they used to be in the dark light. I mean dark room. Right. Also, it has a relation with the food, emotion, and menses, which is not there here, which is not there in the tension headache. Right. Rarely aphasia. So this migraine, sometimes you feel that this patient has a stroke, but they don't have a stroke, because stroke, by and large, you have photophobia, you have some this emotional changes, you have aphasia, you also have dysarthria, you have a numbness. So you feel that something wrong neurologically. But if you do the scan, it's all normal. So this is how the headache present. This all should be there, Dr. Bahar Toprak. Aura, photophobia, food relation, emotion, menses, they will definitely tell you in the history in the exam, right? Which is not there
Sorry,
in
sir.
our scenario.
Sorry, sir. If I can ask you, there's a one recall which I cannot remember clearly. There was a question where I read somewhere about the similar. It was a headache question, and it said the patient did present with aphasia, and it was mimicking hemiplegia. So they were asking for the most likely diagnosis. It was a headache question. So in that case, the answer should be migraine.
Yes, because this is the classical literature I'm telling you, right? So how they
Okay, sir.
present,
Thank you.
how the treatment and prophylaxis. This is only if you remember this one chart only, your headache is done. I'm just
Okay, sir.
always
Thank
time.
you.
I mean, it takes, my dear doctor, takes lots of hours and hours to prepare this, right? But I'm trying to compile so I can make it easy for you, right? So this is the most easiest form. What I'm presenting is one of the most easiest, right? So this is a tension headache. This is migraine headache. Let's see cluster headache. So what is a cluster headache? So episodic pain, episodic. So this is again important. Episodic means pain go usually unilateral, never a bilateral. Unilateral means unilateral lacrimation, unilateral red eye, unilateral nasal stuffiness, and lid ptosis. This is all unilateral. So in short, you can say nasal discharge and lacrimal discharge, right? Unilateral, right? So periorbital pain, right? And specific, they will mention periorbital pain, cluster headache, right? So this is all how they present, right? This is all presentation. This is all presentation of all three. Now see what's the treatment. So if you have tension headache, first line treatment is non-steroidal anti-inflammatory drug and acetaminophen. Right here, the migraine, it's a different. Avoid the triggers. So whatever the triggers, what are the trigger? Some foods are trigger, avoid. Emotion trigger, you keep the emotion under control. Menses, right? So these are the trigger. So you avoid the trigger. NSAID definitely, and as triptan. So Dr. Bahar, NSAID is the first.
yeah.
If it does not get response to NSAID, add the triptan.
Oh, it's okay.
Toprak, got it? right? Because
Got it. Yeah,
whenever
thank
there
you.
is, yeah, but when there is a patient is in the pain, right? When patient is in the pain, you need to abort the pain, you need to relieve the pain, and this is the best is NSAID, right? So first you give it and then think. And what is the prophylaxis? Tension, no prophylaxis. What is I can say, do not do tension, no tension. All is well, all is well, no tension, right? So there is no prophylactic drug. They ask in the exam, oh, this all LL, either they ask how what's the diagnosis, the way we are asking here, either they ask the treatment and they ask the prophylaxis for headache. That's it. This three question in exam. So if the three attacks or more, if the three attacks per month of migraine. So once somebody has migraine, you treated with NSAID, but you want to prevent. So you treated today. Now patient is fine, right? But again, after 1 month, he develops. So if he develops three attack in a month, you need the LOL. LOL is a beta blocker. LOL, propranolol, beta blocker. So this is prophylaxis. And second is a sodium valproate. These are the two drug prophylactic first use propranolol, right? And third, here, here the treatment, here see the treatment is not NSAID. Here, not NSAID. Here the first Dr. Bahar Toprak, sumatriptan. So triptan is for both, right? For cluster headache as well as for the migraine, not for the tension headache. Tension headache, there is no triptan. So triptan for cluster and this. Second is octreotide and oxygen, 100% oxygen, right? So if you inhale the 100% oxygen, cluster headache will get relief. Here, little change in the these things. Here, the beta blocker is prophylaxis. Here, the verapamil, right? Second is the prednisone and sodium valproate for both, right? So sodium valproate commonly, right, for both prophylaxis, right? But additionally, verapamil and prednisone. So these are the few high yield questions they ask in the exam. So you must keep a watch on it. You need to prepare yourself very specific, very, very specific. It's not in general that, okay, what's the treatment of tension, cluster, and migraine? You must know specific treatment plus prevention. Then you never go wrong in the exam, right? So you need to know the specific thing. This is called specific thing. What I discuss here for headache is all specific things, right? So it's a, and this is very nice picture. I mean, though it's not, I mean, classical, but it is very important. I love this picture. See sinus. So this is the frontal sinus, ethmoidal sinus, maxillary sinus. So this is sinus pain. This is sinus pain. So they describe, I have such pain. Cluster, periorbital pain, lacrimation, nasal secretion, periorbital pain, right? Tension, this is a vase like, right? Bend like or vase like in the frontal, right? Bilateral, completely right side as well as left side. This is unilateral, right? And migraine usually, not always. So they describe like our face on the right side of the face, right? Along with the aura, along with the precipitating factor, right? These are the things. That's it. So this is excellent picture. So you need to know, you need to remember what type, where, how, unilateral, bilateral, aura, no aura, vomiting, nausea, cluster, periorbital pain. So if you remember this chart, I think this is absolutely a self-explanatory, right? So you can easily answer any question. That's it. So this is what the thing is. I whatever I explained you, it's there in the form. Not going much in detail. So just last couple of questions. Bear with me. Then we'll pack up probably. 40 years old woman present with abnormal cervical cytology on pap smear, suggestive of CIN, cervical intraepithelial neoplasia. That is the full form of CIN. Cervical intraepithelial neoplasia, grade 3. What is the next best step in the management of this patient? Hysterectomy, you do hysterectomy, you do colposcopy and LEEP, you do colposcopy and cryotherapy, you do conization. Right? So take your own time. Think what is CIN1,
Also,
what is CIN2, what is CIN3. Think over it 10-15 seconds. I'm giving you, not, I'm not in a hurry, I'm not hungry as well. And my sugar level is good, so not hypoglycemic, even end of the 1.5 hour speaking with full strength energy.
colposcopy and lead, sir.
Fine. So let's other two comment.
From the gynae and I solved this, that's why.
Sorry, your gynecologist.
from the gynae section and I solved it already. That
Wonderful. Wonderful. Okay, so you want to interact with me for this question, Dania? Yes, no.
there is a classification. It's a
Your voice is
classification-based
breaking, doctor.
treatment.
Just make your mic little bit closer so I can hear you well.
Sir, I'm not using the headphones or something like that. I got fungal infection, I told you.
Oh,
So that's
sorry.
why I'm
Take rest,
using
take
that.
rest, take rest, take rest. Let's other to discuss. Don't worry. You, yeah, only four question answers in the chat box, and we are 35, 40 people on Sunday. And just we are just three question answers. Kanika, you want to interact? Dr. Kanika. Post more answer. Post. Probably this is last questions. We will pack up then. You looks tired. You all guys looks tired. Yes. Yes, Dr. Nasrin, any comment? Okay, fine, no problem. Got it. No problem, Kanika. Dr. Nasrin. Dr. Rajesh. Yes, Dr. Rajesh, any comment? Yes, Sanjida, any comment? You speak up, don't
Doctor,
worry.
no comment,
Yes.
but as far as I know, it is colposcopy and lead, if I'm not
Okay.
wrong.
So fair enough. It's your answer is absolutely correct, doctor. So now let me ask you a few questions. What is CIN 123 first of all?
Sorry, doctor, can you come again? Oh, CIN is the cervical intraepithelial neoplasia.
Yes. So how you differentiate 1, 2, and 3? What is 1? What is 2? What is 3?
See, that's where I think I'm a bit lost, but all I know is about
Yeah.
the
And,
management.
what's gonna be this invasive
Invasive is
cervical
leak,
cancer?
no? Sorry, doctor.
Yeah. So I want to know, Dr. Sanjida, from you, how you gonna differentiate CIN 1, 2, 3, and invasive cancer?
Okay. So, yeah.
Anyone? Fair enough. This is a learning platform, so I'm glad at least you give the answer. Okay, anyone wants to comment on this four things, CIN 1, 2, 3, and invasive cancer? How you
Sir,
gonna differentiate?
I would like to try, although I'm not, I
Yeah,
haven't
yeah,
done
you try.
gynae at all.
I'm glad.
But
At least
yeah,
you are a brave lady. I appreciate. You are a brave lady.
because it's related to gynae, but still, um,
I'm
so
not
it's
also
basically
gynae. I'm hardcore
okay,
hematologist, doctor. Still, I'm solving lots of MCQ with good clarity. So if
yes,
I
sir,
teach you hematology, how expert you will be? Because my subject is
yes,
only
sir.
hematology.
Sir, so I can try, then you can correct me. So
Yes,
CIN
please.
is basically it's low grade and it usually involves the 1/3 or less of the epithelial layer. Whereas CN2, that is, I think, 2/3 of the epithelium. And then CN3 refers to the abnormal cells that affects more than 2/3. But again, sir, you can correct me because I think I read it a
And
while
what is
ago. So
invasive?
this is what I
Invasive
recall.
and invasive.
Invasive when it's, yeah, invasive when it involves all the layers or goes
All the
deeper
layers
into the
and basal
epithelium.
membrane is in basal
Basal membrane,
membrane is
yes, sir.
rupture. So I have
Rupture. Okay, I
excellent
didn't know
pictures
that.
for
Okay,
you
sir.
guys. So this is
Thank you, sir.
absolutely super picture. I love it, this picture.
Okay.
So right, because I believe in concept, not mugging up. This is normal. So this is absolutely a normal, and this is a basement membrane. This lower line is a basement. So CIN1 is a mild dysplasia. What do you mean by mild? 1/3 of the thickness is involved. So here see all pink cell, here pink and blue cell. Now here see the pink and blue cells increasing. So this is up to 2/3 is involved. I mean mild. This is 1/3. This is almost all blue. 2/3 of cells are involved. 2/3, right? And this is almost complete thickness. All the cells are changed. You can see. So this cell, you see the normal cell, right? This is normal, and CIN 3, right? 100%. So less than 1/3, 1/3 to 2/3, more than 2/3, or almost 100% involved. But what the difference between carcinoma in situ and invasive? Basal membrane is intact. Here you see the cells are coming out of the basal membrane. So basal membrane is gone, right? So this is the mildest form, right? This is little more advanced. This is more advanced. This is carcinoma in situ. And then, so if somebody has a 2024, somebody develops CIN1. So what time frame they will develop the invasive carcinoma? Probably by 2034, they develop. At least 10 years it takes. At least 10 years take. So how you can prevent this? How you can prevent this? There is a one test, pap smear plus HPV, human papilloma virus. Can tell me, Amina, which are the four commonest virus which can be the most four commonest strain of HPV? Do you remember? High yield question in exam. 6, 11.
Yes, sir. Sir, it is I think 18, HPV 18, 16. I just recall these two, sir. I think
Yes,
16 and
that's
18
it.
I read somewhere.
So Amina, your homework is what are the commonest strains of
Yes, sir.
HPV, right?
Okay,
What
sir.
is a quadrivalent vaccine? Quadrivalent vaccine. What is nanovalent vaccine? What is the screening
Okay,
age
sir.
of cervical cancer? Screening age. Do you know what is the screening age of cervical cancer?
No, sir. I'll look it up. I'll study. I know
No, no,
well.
I will
Okay.
tell you, don't worry.
Okay, sir. Okay, sir.
21 it will start and 65 it will stop. This is the one question in exam. So earliest you can start at 21, 65 you can stop,
Yes.
because after 65 there is no mortality advantage. No mortality advantage, and that is why you stop. Second thing is the frequency.
Okay,
How
sir.
frequently you do? Every 3 years. Every 3 years. If you do every 3 years, do pap smear. If somebody wants to do 5 years, then you do the HPV. So if you do HPV plus PEP every 5 years is okay. So today you do pap smear and you do HPV, right? And HPV is negative, human papilloma virus is negative. Repeat after 5 years, not 3 years, but
Yes,
alone,
sir.
only pap smear. Then it is every 3 years. So 21 every 3 years up to age 65. What are the strains
Yes,
common
sir.
involved in it? Another term is OSCAS. OSCAS, atypical squamous cell of uncertain significance. So if you do the pap smear, if OSCAS comes, how you manage? Do you know how you manage? So those
No,
who
sir.
don't know about the things, open up the chapter cervical cancer and pap smear from Master the Board. All the things are given extremely well, complete clear cut. This is absolutely high yield point, cervical cancer, right? Because it is second most commonest cancer after breast cancer in female. Here the screening test is mammogram. Here the screening test is pap smear. Both can reduce the mortality of the patient, and that is why it is asked in each and every exam. Sometime 2 question, 3 question, 4 question for breast and for cervix. So you must know. If I tell you, then almost one dedicated lecture for cervical cancer and pap smear and related issues. But this is the high yield I explained you. So you go and read up the chapter of cervical cancer. So that's all for today from my side. I spoke 1 hour and 30 minutes. Hopefully you enjoyed the session. So before ending, okay, so sorry, let me finish the answer. Sorry. So answer is a loop and colposcopy and leap. What is a colposcopy? Colpo means vagina. Scopy means visualization. So visualization of vagina, you do the scopy and leap. What do you mean by leap? So leap full form L means loop, electrosurgical excisional procedure. LEEP. Sorry. So you don't need to just mug up the LEEP. You must know the full form of loop electrosurgical excisional procedure. That can be done for the CIN3. So what can be done for CIN1 and 2? Right? So that is your homework. If it is CIN1, what is the treatment? If it is CIN2, what is the treatment? CIN3, what is the treatment? And cervical cancer, invasive basement membrane is gone. What is the treatment? That's your homework. That's your homework. Right? So that's it. So this is CIN3. The treatment is a LEEP, colposcopy with LEEP. So that's all for today. I want and wish that anybody, even with start with Amina, how was your experience of class today? Anything you learned new in this class today? Or what's your experience? Yes, please.
Yes, sir. Sorry, my my mic was a bit sick. Yes, sir. I think the concept behind every question, it just leads to more answers to different questions also. For example, the headache question. While doing it, it seemed like a very simple question, but when you showed the chart, it just made sense. So for sure, I know if we do that chart, we won't make a mistake in that one. So I think the clarity on small details is very clear.
Excellent. So just concentrate on that as well. Yes, Dani, any comment?
Okay, sir.
So very informative and worth taking that the seniors they all are involved in. Excellent. Worth taking classes.
Yeah, you motivated me today on Sunday.
Yes, of course. I'm saying truth.
And
Not
anyway,
like
I'm a quite highly motivated. You can see in my every mock test. I'm never like low and dull and hypoglycemic. I'm absolutely
Alhamdulillah.
energetic.
God will give you more courage and healthy, wealthy
and the
life.
and the
Amen.
and the interaction also that you encourage, I think that really pushes you, so that's very important also.
And you
Wonderful.
never skip a one thing, and you never skip a one thing that you wanted to clear all the things, itsy bitsy, you like you need to clear it, and you are doing it very well.
Thank you very
Thank you,
much.
sir. Thank you so much.
Anyone who joined the first time, the last opinion, your experience overall. Anyone who joined the first time today, the first class of mine.
Yes,
I
sir.
don't know. I mean the yes, please, sir.
I am Rajesh and Dr. Rajesh.
Yes, sir.
Joined from Mumbai. Yes, sir. It's very informative, sir. You are teaching very deeply.
Sorry, sir.
You are teaching very thoroughly.
Thank you very much, sir. Thank you very much
Yes,
for
sir.
your kind feedback. So don't miss out our mock test on Sunday, same time,
Yes, sir.
right? So you will enjoy. Everyone is enjoying. So that's it. Anyone else? Last but not the least, anyone? Something new you learned, probably you will not thought of earlier, right? Or probably that can change your approach for the preparation, something like that. Dr. Mitu, any idea? Dr. Mitu, I think you also joined first time, if I'm not
No,
wrong.
no, sir, I have joined earlier also once.
Okay, great. Sorry. Okay, so how did you
It was
enjoy
really good.
something new for you today?
Sir, we are getting all the details. Actually, we are learning more.
Sorry?
It is very descriptive. बहुत अच्छा है class. It is really good.
Wonderful. So I think you can duplicate this, what the way I'm doing. This is my way of style. Probably you have little different style, but what I mean to say, you just go little bit in detail. Don't just mug up, okay, answer कर दिया उसका हो गया. Doesn't work in that way. Try to understand what exactly and try to make some here nearby questions, right? CIN1, we told 100 times, but we don't know what is CIN 1, 2, 3. You understand? So it's a small thing, but it brings more clarity to you. What is HPV? What is, I mean, how many strains involved, right? What happens if it is Oscars comes? What if it is a HIV with Oscars? That is again a question in exam. So related questions you need to do, and this all, honestly speaking, this all from our website. So this is little in a polished way, and also on the website as well, very nicely given. So if you do the mock test repeatedly, if you do the targeted subjects daily, right? So I think it is all on the website, nothing new. I did not bring from any other book. It's all 100% on our medical MCQ website, right? in a different section. Probably the CIN wala is in oncology, and then pulmonology and all different. But it all questions are there. So try to concentrate, try to understand the concept. And one last request: do maximum mock test. Maximum mock test you do. So that is how you get to know that where you are exactly doing the mistake and what are your mistakes. So that brings more clarity and you can self-assess, right? That okay, fine. This time you scored 50%, next time 55, 60, 65. So you can monitor your progress, right? And if you feel any problem, difficulties, blah blah, feel free to contact me. My number is here. Everybody probably have my number. This is my number, right? So I highlighted here. This is my number. So those who do not have my number, you just save this number, you WhatsApp me, so I can guide you a little bit further. So thank you very much once again. Keep in touch and enjoy your Sunday. We'll see you soon. Thank you very much. Good day.
Thank you, sir.
Bye bye. Take care.
Yeah, thank you very much, sir. Bye.
Bye bye. Take care. Take care. Bye bye.
Thank you, sir.
Thank you. Bye bye.